During a busy shift in the outpatient department, the sheer volume of general fever presentations can be overwhelming. Mixed within these routine viral cases is enteric fever, commonly known as typhoid. It is one of the most frequent bacterial infections in the clinic, yet it is consistently mismanaged. The modern threat is the rise of multi-drug resistant, or MDR, typhoid strains. MDR means the bacteria has evolved to survive the standard single antibody treatments that clinicians relied on for decades. Legacy monotherapy now routinely fails. To combat this, we need a rigid, standardized clinical algorithm for identifying, diagnosing, and treating enteric fever at the point of care. This flowchart shows the 3 phases of our clinical algorithm: presentation signatures, diagnostic chronobiology, and the dual therapy protocol. Standardizing this workflow provides a framework to navigate diagnostic timing and antibiotic selection when facing resistant strains. Step 1 in the algorithm is identifying the physical footprint of the disease during the initial examination. The cardinal anomaly to look for is the step-ladder fever pattern. This chart tracks a patient's temperature over 5 days. Notice the red line moving upward in a distinct staircase pattern. The peak temperature rises incrementally day over day, never fully returning to the baseline. The second signature is relative bradycardia, a surprisingly slow heart rate relative to the high core body temperature. Normally, high fever triggers a rapid pulse, but with typhoid, the blue pulse line remains stubbornly flat while the red temperature climbs. The third crucial physical exam marker is found inside the oral cavity, the coated tongue. You will observe a persistent, thick white layer covering the dorsal surface of the patient's tongue. Accompanying this triad, patients will often report pronounced lethargy and localized abdominal pain, confirming a severe systemic toll. Recognizing this triad, step-ladder fever, relative bradycardia, and a coated tongue, gives a clinician evidence to suspect enteric fever days before laboratory results become viable. Moving to the diagnostics branch of the algorithm, we encounter a severe timing trap. The most common diagnostic error in the OPD is ordering a Widal test immediately upon fever presentation. The Widal test is a serological assay that looks for antibodies against Salmonella bacteria. This timeline chart illustrates the chronobiology of the Widal test. Antibody titers are simply not detectable in the first week. Trusting an early Widal test forces you into a false negative zone, leading to dangerous delays in treatment. The immediate alternative requires analyzing specific hematological markers within a basic complete blood count, or CBC. The first anomaly to spot is leukopenia. This is an abnormally low total white blood cell count, dropping aggressively below the normal threshold. But the most specific CBC marker for early typhoid is absolute eosinopenia, a severe drop in disease-fighting eosinophils. In enteric fever cases, this eosinophil count routinely plummets to exactly 0%. You can supplement these findings with a TyphiDot test, which detects initial IgM and IgG antibodies earlier than a Widal assay. Diagnostic timing dictates intervention. Before day 7, clinicians must ignore the Widal test entirely and rely on CBC anomalies like eosinopenia to proceed with treatment. Entering the treatment branch of the algorithm, the baseline protocol dictates that we assume the presence of multi-drug resistance. The primary decision node relies on the patient's gastric tolerance. Are they stable, and can they tolerate oral medication without vomiting? This decision tree shows that for stable patients, single drug therapy is insufficient. You must initiate a dual antibiotic strategy. The first pillar of this dual therapy is tablet Cefixime at a 200 mg dose. The dosing schedule requires 1 tablet twice a day, post-meals. This course runs strictly for 10 to 14 days to fully clear the infection. The second pillar is tablet Azithromycin at a 500 mg dose. Prescribe 1 tablet once a day, also after meals, for exactly 7 days. For symptomatic management, include a 650 mg paracetamol tablet, administered only as needed for acute fever spikes. Pairing a cephalosporin with a macrolide aggressively bypasses modern bacterial resistance mechanisms, ensuring complete eradication in stable outpatients. Returning to the primary decision node, we establish the escalation trigger. The patient is actively vomiting or presenting with severe gastrointestinal intolerance. At this trigger, the protocol shifts immediately. Abandon oral medications and move to intravenous therapy. On the decision tree, the IV escalation branch designates injection Ceftriaxone, 2 grams, administered once daily. This antibiotic requires strict dilution within 100 milliliters normal saline bottle. The speed constraint is vital. The infusion must run slowly over 20 minutes to prevent adverse reactions. If the patient also exhibits severe lethargy or weakness, administer 500 milliliters of Ringer lactate as a slow IV drip to restore hydration and electrolytes. Gastrointestinal intolerance is a definitive clinical red line. Recognizing it early and escalating to IV ceftriaxone stabilizes the patient and prevents rapid deterioration. This complete diagram visualizes the fully constructed OPD protocol from start to finish. You recognize the physical triad, navigate the diagnostic timeline using early hematology, and deploy the appropriate pharmacological track based on gastric tolerance. However, there is a final, non-pharmacological variable required for complete recovery: strict environmental control. You must communicate absolute dietary restrictions to the patient. They must consume 0 outside food. For hydration, the patient must consume exclusively boiled water at all times to prevent reinfection or further gastrointestinal aggravation. Even the most rigorous dual antibiotic therapy will fail if the patient is re-exposed to contaminated sources. Patient education is just as critical as the prescription pad.